The first thing that I think is most important when you start in a clinical research position, coming into it very green, maybe just coming into it out of college, and you're not going to jump in and start, seeing if a patient qualifies for a trial immediately. But what you'll do is maybe start seeing their follow-up visits and start, being able to follow through the exams and understand the different layers of the eye and understand what we're looking for when we say, PVD and things like that. You really have to learn ophthalmology and retina and the diseases. That's kind of the big thing. The number one thing is when any patient comes into research, of course they have a relationship with our doctors. So we always want to kind of build on that foundation that our doctors have already established with them. And we want to make sure before they enter into any study that they have all of the understandings of the trial, which is the consenting process. We want to make sure, of course, that they're comfortable with the decision they're making and they're not just doing it for their doctor. The way that we approach our referrals, especially in this clinic, is when the doctor sees a patient and they say, I think this patient will qualify, what do you think? And so typically they'll come grab a coordinator, we'll look over the patient's stuff, make sure they just meet very surface qualifications, and then we'll go and just have a conversation with the patient. We can't ask any medical history questions or any personal identifying questions that could exclude them for the trial or make sure that they make it into the study. Unfortunately, a patient maybe agreed to it because their doctor and they're not 100% sold on the research. So when I'm having this conversation, typically I'm asking, would you be interested in this kind of study, and kind of setting the parameters of what the study's design is, what would be necessary of them to complete to enter into the trial and things like that. So I'm not diving in deep, you had a heart attack 6 months ago, I don't think this is going to work or anything like that. It's very surface. So once a patient comes and shows up for a screening appointment, we've already done the background work to make sure that they will qualify. Once they're in office and before the consenting process even start, we'll make sure that they actually sat down and took the time to read the consent for themselves so they have an overall broad understanding of what they're getting themselves into. You have to trust your patient first and foremost. So we have to trust that when they're telling us they read the consent that they actually had. And it will show through the process if they did read it or not. If they say yes, then we can start the consenting process. If they say no, then we have to leave them in a room by themselves and they have to sit there and read the consent. I'll sit down with the patient and I'll make sure to answer any questions that they have. And again, if they actually read the consent, this is a part where they're going to ask questions. And this is a part of the consent that's really important that you have a sort of general understanding of the disease process. Because they're asking, I have diabetic macular edema. Well, if you don't understand diabetic macular edema, how can you answer those questions? If you don't understand the protocol of the study, for example, it's a 2-year trial, how are you going to look at them and say, oh, it's, I don't know the length of the trial, or things like that. So it's important to understand the design, first of all, and then also the study. It's really important that you're comfortable with your consent form, that you're not sitting reading verbatim word by word, this disease is blank, this study is blank. A lot of the times when I'm consenting, I don't really look at my consent form, I use it as page markers so I know what to hit on next. I'm not reading from it, I'm having a conversation with the patient versus reading at them, because when you're reading at them, it's not personal at all. They could potentially feel like they're just another number, another research subject, and you don't want your patient to feel that way. Dr. Wyckoff always says that research patients are the VIP in the clinic and they need to be treated that way. And so you need to be able to have a meaningful conversation with them without having to look down at a piece of paper every 2 minutes. After they read the consent, I'm going to ask them, I need you to demonstrate the ability to read out loud for me. And the reason why we have to do this is we have to make sure that that patient isn't in a vulnerable population. If a patient requires an oral consent, we need to be able to check our consent form to make sure that you have a witness line. And you'd also have to check your institutional review board to make sure that you have been approved to consent these patients in this vulnerable category. If they have a medical power of attorney, that's a situation as well that you would have to check with your institutional review board. If they're illiterate and they are unable to read, they never learned how to read, that's an easy fix. We can bring a witness in. Certain studies may allow for an illiterate person to have a witness present during a consent, and sometimes it's not allowed. So it really depends on your institutional review board. If the patient is unable to read based off of poor vision, number one thing is to offer a magnifying glass. If that's not good enough, offer a bigger magnifying glass. If they're still unable to do that, then you will have to get a witness and do an oral consent. And same thing with illiterate people, we have to do the consents orally. And when you say orally, that is word for word, page by page. So these are 30-page documents that you're going word for word through. For an oral consent, I will be the one who's reading the consent to the patient verbatim from the consent form. I will bring in an additional party to act as witness. The person conducting the consenting process can perform the oral consent. They can read the consent form, verbatim, word by word, and then we would bring in an additional party. And in some cases, in some studies, it can be, another patient in the clinics, their family member. Sometimes it has to be a completely separate patient that's not identified with the PI at all, or the principal investigator, which in this instance would be Dr. Wyckoff. It all just depends on your institutional review board, your IRB, and they set these guidelines for people of this vulnerable population and how we can consent them. If they are able to demonstrate the ability to read, you're good. It's really important that you take the consent page by page and hitting every paragraph. You don't need to be skipping through pages. You need to stop at every paragraph and hit something out of each one. Even if it's something little like HIPAA, you need to tell the patient their rights and what they're getting themselves into. A lot of the times when I get to the adverse events section, or kind of the cautionary, what could happen, your benefits, your possible disadvantages, I always read those line by line. That way the subject, and unfortunately if something were to happen down the road, they can't say that you didn't do your part in telling them what could happen to them. And so following the consent, we're going slowly, we're taking our time. When we get to the signature page, of course we're going to have all of and hopefully it's just a normal consent where you sign, the patient signs, and it's done. Once you complete your oral consent going through page by page, line by line, you would make sure to go to when you get to the signature page, you would sign the consent form as the person conducting the consent. And we'd have to get the witness's signature as well. Make sure to get the signature of the potential subject, which will be the patient you are consenting. You're going to fill out any questions that the patient asks during the consenting process. You're going to make sure that you have given the patient their copy of the consent form. Before you can give the copy, though, you have to make sure you check with another coordinator. Even if you are a coordinator yourself, you're going to hand off your informed consent to another coordinator. And the reason for this is they're going to check every page, first of all, to make sure you have 1 through 30. That way you're not missing a page here and there. And then from there, they're going to make sure you didn't miss any signature pages, you didn't miss any steps, and that everything is completed accurately. They'll sign off on your consent on your ICF checklist, and then at that point you could give the patient a copy of the consent and making sure that they know to keep it for their records. Following that, it's really important because at that point, any patient that walks in and gets consented, they are a part of the study in some form or fashion. Whether they get enrolled or whether they screen fail, they have signed a consent. They are somehow involved in this study, so they have to have a screening number. And if they don't have that number and they somehow slip through the cracks, it's just not good. So definitely assign a screening number directly following the consent. Kind of a really big thing to keep in mind for a consent form, it's an ongoing document. It doesn't end. And so a lot of the times in a trial, you're going to get updated protocols. And so when that happens, we have to reconsent a patient. And so when a reconsent form comes out, the entire consent's going to be the same with just little modifications where the sponsor sees fit. So if there was a one-line change on page 36, but I've orally consented this person, I have to start from 1 to 36, and I have to verbatim go through that consent form page by page, line by line. If a patient was able to demonstrate the ability to read and they came into clinic or they came in for their research appointment and we're reconsenting them, all I'd have to do is go over the changes made to the consent. So all that's changed is that they've added retinal vein occlusion as a potential ocular AE, and once she understands that and reviews it, and of course demonstrating the ability to read every single time she's reconsented, then she'll sign the form, and then we'll be on our way. So it's a lot faster, of course, than just orally reconsenting. You know, everybody's amazing, but it's like there's something about your first person who consents you that's always really special. Like, I just saw a patient today and I consented her, and she told me, I haven't seen you in, 3 weeks, where have you been? But her and I will always have that special connection because I led her through her screen in a way that was very personal, and it wasn't me reading from the paperwork and checking my boxes. It was very much me getting to, like, I know her husband and I know her, she tells me about her kids, and so it's not so much, here's your number, let's get you in the study and we'll see you once a month for the next 2 years. It's very much about, by the end of that visit, which is going to be 4 or 5 hours, you have some sort of relationship where they're excited to come back, or you give them their business card and they feel comfortable calling you and checking in on their eligibility or checking in on their lab results or whatever it is.